Thank you so much for inviting me. You know, it really is such a privilege to be here, and I am really looking forward to spending the next 2 days with you and learning from you. And so I'm going to speak with you a little bit about what we've been doing in Minnesota. Those of you who were here last year may remember Dr. Amanda Bedoin, who gave a taste of what we're doing. And I will tell you what has occurred in the interim as well. I'd like to begin just taking you back a little bit to what life was like before we had effective antibiotics. And this is a quote from Lewis Thomas from his book, The Youngest Science. For most of the infectious diseases on the wards of Boston City Hospital in 1937, there was nothing to be done beyond bed rest and good nursing care. I remember the astonishment when the first cases of pneumococcal and streptococcal septicemia were treated in Boston in 1937. The phenomenon was almost beyond belief. Here were moribund patients who would surely have died without treatment, improving in their appearance within a matter of hours of being given the medicine, and feeling entirely well within the next day or so. We became convinced overnight that nothing lay beyond reach for the future. Medicine was off and running. And indeed, the ability to have effective antibiotics has impacted almost every area of medicine. It has enabled us to do transplant surgery. It has enabled intensive care. It has enabled chemotherapy and treating immunocompromised individuals. Just to give you a relative sense of the impact of antibiotics, here you can see in this slide with data put together by Brad Spellberg, who's an infectious disease physician in California, the impact of antibiotics on the death rate from various infections. And you can see that the pre-antibiotic death rate ranged from about 11% for a skin infection to 100% for a heart infection or endocarditis. The change in death rate with the ability to use effective antibiotics decreased death from 75% to 25% for endocarditis, and a drop in death rate down in skin infection, so that was less than 0.5%. By comparison, a treatment that we all think of as very effective, the treatment of heart attacks with aspirin or clot-busting drugs drops the death rate by 3%. So just think about that. A drop by 75% for heart infection, 25% for pneumonia, 30% for hospital-acquired pneumonia, 60% for brain infection, and 10% for skin infection, compared to dropping by 3% for using a clot-busting drug. CDC has a wonderful cartoon that really, I think, sets the stage very well as a picture for what is going on between bacteria in the acquisition of resistance. And here you can see a susceptible bacterium that has a ring chromosome. That chromosome has genes on it that undergo mutation, and now you have a new resistant organism. However, resistance can also be acquired from other bacteria that are in the area, so to speak, in which that they can transfer genes. And so the acquisition of genes via plasmids, via transposons, other mechanisms can also result in resistant bacteria. We use the term selective pressure. We mean by this when bacteria are exposed to an antibiotic, susceptible cells die. Those that are resistant or acquire resistance through mutation, genetic rearrangement, or acquisition of genes survive. With reduced competition from susceptible bacteria, the resistant bacteria can now thrive and outcompete the wild type or susceptible bacteria. However, it's important to remember that antibiotics also impact normal flora, which otherwise could limit the expansion of pathogens. Non-pathogenic but resistant bacteria can impact the microbial niche by increasing the reservoir of resistance genes. And I'd like to now take you forward to August 2008. This is from a New Yorker article. And it goes as follows. In August 2000, Dr. Roger Weatherby, an infectious disease expert at New York University Tisch Hospital, received a disturbing call from the hospital's microbiology laboratory. At the time, Weatherby was in charge of handling outbreaks of dangerous microbes in the hospital. And the laboratory had isolated a bacterium called Klebsiella pneumoniae from a patient in an intensive care unit. It was literally resistant to every meaningful antibiotic that we had. And in fact, we have started to see pan-resistant infections in the United States. A year ago, there was a woman in Nevada who died from a pan-resistant infection in which there were no antibiotics that could treat her. There are pan-resistant and extremely drug-resistant infections in many parts of the world, and in fact, many of the plasmids that we see carrying a huge number of resistance genes, and in this case it was the New Delhi metallobetalactamase, carbapenemase gene. These plasmids carry resistance genes and are more frequent in places like India. And in fact, there were on the order of 50,000 newborns in India that died because of very resistant infections. And they unfortunately had a practice of insisting that women be admitted for giving birth. There weren't a lot of beds, and so there were multiple women per bed, and the babies all received an IM injection of an antibiotic at birth, resulting in really significant problems. Other problems in India are, and this brings in the environmental impact, the lack of sanitation, thereby increasing the exposure of people to resistant organisms. CDC came out with the threat report in 2013. I think we're probably all familiar with this, but just to remind you that the report indicated that at least 2 million become infected with bacteria that are resistant to antibiotics, and at least 23,000 people die each year as a direct result of these infections. These were data that were put together in 2013, and certainly if we looked at the data now, they would surely be increased. The total economic cost of antibiotic resistance to the U.S. economy has been estimated at $20 billion for direct healthcare costs, and when you take into account additional costs to society for lost productivity as high as $35 billion per year. And now we're going to move into stewardship. And when we talk about stewardship, it's interesting to keep in mind that the first champion of antibiotic stewardship actually was Alexander Fleming himself, the gentleman who discovered penicillin. And this is from an interview in the New York Times in June 1945, where he said, "The microbes are educated to resist penicillin, and a host of penicillin-fast organisms is bred out. In such cases, the thoughtless person playing with penicillin is morally responsible for the death of the man who finally succumbs to infection with the penicillin-resistant organisms. I hope this evil can be averted." And so when we talk about antibiotic stewardship, what we mean is this is a process of improving antibiotic use by using coordinated actions. And this is information from CDC, and the way we approach it is to recognize the importance of antibiotics, that they are needed in human as well as animal health, that antibiotics are a shared resource. We focus on optimizing use of antibiotics, not withholding antibiotics, because we certainly recognize that antibiotics are important when indicated. And the goal is to optimize the use, to choose the right antibiotic for the infection and the patient, to give the right amount of antibiotic, and to give the antibiotic for the right amount of time. So drug, dose, and duration. It's a balance. We don't want to have unintended consequences from prescribing. These include toxicity, adverse drug effects, risk of developing severe infections in people such as Clostridium difficile. We know antibiotics create the selective pressure for resistant organisms, and there are costs. However, there are also unintended consequences when we don't use antibiotics. There can be untreated and more severe infections. Disease can spread in a population. Diagnostic uncertainty, negative patient or client relationships, and potential litigation. You'll hear more about this, but the CDC has come out with core elements of antibiotic stewardship, and the first core elements came out around acute care. These include the following: leadership commitment to dedicate resources, accountability, drug expertise, to act, and this includes the following: to come up with either a systematic evaluation of ongoing treatment needs after 48 hours, so you reassess after 48 hours, you look at culture results and fine-tune the therapy. It could be a pharmacy-driven intervention, such as requiring authorization or adjusting doses. Infection-specific intervention, such as taking a common syndrome like community-acquired pneumonia or UTI, and having a standardized approach to track the antibiotic prescribing, to track resistance patterns such as antibiograms, and to provide regular reporting on antibiotic use and on resistance to staff involved in the hospital, as well as education, informing hospital staff about resistance and optimizing prescribing. In human health care, we take approaches either at the pharmacy level, and so that can include having a formulary, to require consultation from a pharmacist, to audit processes. Other processes to optimize prescribing, reviewing within the 48 to 72 hours, using antibiograms, using an audit to look at mismatches between the therapy and the organism, to identify opportunities to switch from intravenous to oral, and to focus on protocols, such as for urinary tract infection, having an algorithm, an order set, etc. And now let's move to One Health. So this is a definition from the American Veterinary Medical Association. I will note that One Health Day is coming up on November 3rd, so it's a very opportune time to be talking about One Health. But One Health, as defined by AVMA, is the integration effort of multiple disciplines working locally, nationally, and globally to obtain optimal health for people, animals, and the environment. Together, the three make up the One Health triad, and the health of each is inextricably connected to the others in the triad. Understanding and addressing the health issues created at this intersection is the foundation for the concept of One Health. And why is this important? Well, in Minnesota, we really felt that we needed to take this kind of approach in order to fully understand what was going on with antibiotic resistance and how to be most effective in our efforts around antibiotic stewardship. And so recognizing the story of the elephant and the blind men, and each feeling a different part of the elephant, and it really is only through working together, I think, that we get the correct grasp of the situation. And we wanted to go from A, where here you have a man standing on his soapbox, and one person's sleeping, and another person is thinking about something else and daydreaming, and two other people are in conversation, to B, where everyone is working together, understanding the issues together, and coming up with an approach together. In Minnesota, we have had a history of working with partners in antibiotic stewardship, as well as in other things. And our first collaborative work was in human stewardship, and that dated back to the early 2000s, where we worked with our medical association, our pharmacist group, the health plans, the Minnesota Department of Health, and we created something called the Minnesota Antibiotic Resistance Collaborative, and we worked together on developing tools that could be used in daycare as well as tools for long-term care on how to approach whether an antibiotic is needed. And what I mean by that is we created curriculum for daycare workers, because their child care, there's a huge amount of antibiotic use. Very often a child can't go back to the daycare unless they have been on an antibiotic for 24 hours. And we found that, in fact, oftentimes these were upper respiratory infections due to viruses. And so coming up with a simple thing like a viral child care excuse sheet that the physician or clinician could check off, and what they needed was rest and Tylenol and fluids. We came up with a cough and cold kit for adults because there was this pressure on the clinicians to give something to a patient who came for care. They wanted something concrete. We create for long-term care the utilizing guidelines published guidelines on the approach to urinary tract infection versus bacteriuria, the presence of bacteria in the urine. A lot of elderly have bacteria in the urine. It does not imply that they're having an infection. And so teaching the people in long-term care what the indications were, coming up with curricula for the nurses' aide, for the clinicians. We also worked on pulling together in a statewide conference between 2012, 2013, and 2014. We had 3 statewide conferences on how to put together an antibiotic stewardship program, how to convince the CEOs of the hospital that this was a good thing to do, what it might look like at a critical access hospital, versus a tertiary care hospital. And then we came up with some tools for putting together stewardship programs in acute care and long-term care. We, and nationally, have worked on antibiotic stewardship, and there have been quite a few things, including quality assurance programs, residue prevention, so prevention of residues of antibiotics in milk, the USDA veterinary accreditation modules, judicious antibiotic usage guidelines developed by AVMA and allied veterinary organizations. And in fact, we've been fortunate in Minnesota in our veterinary school to have quite a few of the faculty actively engaged in developing antibiotic stewardship guidelines. As well as, in addition to guidelines for food animals, really important to work on antibiotic stewardship in companion animal practice. There's a lot of overuse of antibiotics in that setting. Similar to the elderly, in long-term care, there actually is overuse for feline UTIs, I am told. And so that is another area that we're working on. What about the environment? Antibiotic residues have been found in groundwater and surface waters in Minnesota. And in our University of Minnesota faculty, we do have environmental experts who have done some of this work in collaboration with the Pollution Control Agency and the U.S. Geological Survey. There has been a complex mixture of antibiotics and metabolites found, and trying to understand the urban as well as the agricultural pathways to contamination. So we have concern about the farms, but we also have concern about the hospitals and the impact the hospitals have. And so one of our big questions is, how do antibiotics in the environment influence overall resistance, and how does antibiotic exposure impact the ecology as well as human health? And finally, how can we mitigate the impact on the environment? And so putting all this together, it was really, the time was ripe in fall of 2015 to start thinking about how we can address things together. And we want to take a multi-partner approach. And so in the fall of 2015, the Minnesota Department of Health engaged with the Minnesota Board of Animal Health, Minnesota Ag, Minnesota Pollution Control Agency to put together a steering group. And we asked our sister agencies who need to be on this steering group. Who are the appropriate stakeholders from academia, human and veterinary clinical practice, professional and industry associations, healthcare systems, and producer organizations to help us with this issue? And we put together our steering committee. We decided that we would have a summit in January of 2016, and we contacted the various stakeholders, and we gave them questions ahead of time and asked them to think about the various issues involved with antibiotic stewardship and antibiotic resistance. At the time of the summit, we had a facilitator who worked with us so that we could figure out what our commonalities were. And I will show you that in a minute. What is it that we all fear? What is it that we all want? And through really working together across the disciplines, we did develop a consensus on how to move forward. And our aim was to develop a strategic plan. And so we worked between the winter and spring of 2016 to put together that strategic plan. We did it through disseminating the discussions that took place at the summit. We formed technical work groups in order to develop the plan, and then we asked for input from other stakeholders to refine the plan. And then on July 1st, 2016, we launched our strategic plan. And as a part of it, we needed to seek out additional resources because we didn't really have funding for this effort. But we figured it was extremely important to do. And so we did begin to implement with in-kind support from across the board. We determined our mission to be as follows: a collaborative environment to promote judicious antibiotic use and reduce the impact of antibiotic-resistant pathogens of human, animal, and environmental health importance, with a vision as follows: Minnesota leaders in human, animal, and environmental health will work together to raise awareness and change behaviors to preserve antibiotics and to treat infections effectively. Here are our common wants and fears. What we want is collaboration, common goals, to recognize alignment and differences. Our fears are ineffective antibiotics, untreatable infections, death, and adverse effects. Our wants, decisions made on unbiased data, not politics or public perception. Our fears are reactionary decisions without sound science and incorrect assumptions. Wants are community understanding and informed participation. Fears, overregulation, replacing careful medical assessment. Our wants are to minimize environmental contamination for safe food and water supply. And fears are negative impact on the environment and ecosystem. And so here is a photo of the Commissioner of Health. We held a joint press conference on July 1st with the 4 state agencies together, with the commissioners of those 4 state agencies, to unveil our 5-year strategic plan for Minnesota. Our goals were to promote the understanding of One Health antibiotic stewardship. And this would include sharing resources through an online platform to support public engagement on antibiotic use and to hold exchanges among practitioners in different fields. We wanted to improve human antibiotic stewardship, to make tools available to track antibiotic use across the continuum of care. This is not all that easy to do. There are not simple methods to track antibiotic use. There are some commercial data sets that one can purchase for outpatient antibiotic use. There are now some vendors on the inpatient side that are working on enabling the use of pharmacy data through the CDC antibiotic resistance and use module. And in long-term care, you can imagine it is tremendously difficult to track antibiotic use because residents in long-term care can get antibiotic prescribing from their practitioner in the community. They can have it from a recent hospital admission, where the antibiotic was prescribed during the hospitalization and continues over, or it can be prescribing from a clinician at the long-term care, perhaps their clinician, perhaps an on-call clinician, and there is not a pharmacist who's there every day. There's a consulting pharmacist who comes in periodically. So that is an area challenging to track antibiotic use. We want to set state human health antibiotic goals so that there's a recent publication from CDC that looked at very large databases of outpatient care and found that 30% of outpatient antibiotic use was unnecessary, not indicated. And in fact, when we look at our data in Minnesota for acute bronchitis, we're finding that on the order of 75 to 80% of outpatient clinics are still prescribing antibiotics for acute bronchitis, which is essentially a chest cold. So we need to do better, and I have found that when you give clinicians something measurable and you tell them what their peers are doing, it is more effective than to just say, please don't prescribe antibiotics for acute bronchitis. We also have developed an honor roll recognition for acute care facilities and are working on developing an honor roll recognition for long-term care facilities. And these are where we recognize on our website the gold, silver, and bronze facilities who are doing stewardship. And to get a gold level, not only are you doing the CDC core elements, but you are actively engaging with other facilities and helping them to do stewardship as well. Because we do know that there are small community hospitals, critical access facilities that don't have an infectious disease physician, that don't have pharmacists with infectious disease training, and so we want to encourage that as well. We also want to improve animal antibiotic stewardship, and so part of this is communicating all the great work that's occurring on the national level to promote animal agriculture best practices, to increase access to stewardship resources for companion animal medicine, and to facilitate public engagement on animal stewardship. And finally, another area we're working in is the environmental area. And so we are developing an antibiotic footprint tool. This is meant to take into account the impact of antibiotics in the environment and to help prescribers make choices to decrease their own antibiotic footprint. This is Dr. Amanda Bedoin, who is our One Health Antibiotic Stewardship Director, and you will note that she's a veterinarian, but she also has had training at CDC. She was an epidemic intelligence service officer at CDC and had worked at CDC on antibiotic resistance and developing surveillance systems, including systems abroad, in Vietnam in particular. And so she really has the kind of breadth and ability to work in both the human world and veterinary world. Our structure is as follows. We have 4 technical working groups. The One Health work group that promotes the understanding of One Health across the disciplines. And we have had a series of exchanges among practitioners in human, animal, and environmental health. And they also work on public outreach, developing information sheets for the public on various issues, and I'll show you some of those. A human antibiotic stewardship work group, which is involved in developing goals, a roadmap, incentives for stewardship programs in healthcare facilities. An animal antibiotic stewardship work group, and I will say animal antibiotic stewardship workgroup is headed by the person who leads the Board of Animal Health in Minnesota. It is a very large, active, and engaged work group, and they have really been doing tremendous stuff. Their work has involved supporting stewardship efforts and agricultural best practices, producer quality assurance programs, working on how we can get some on-farm use, and working on companion and animal stewardship resources. The Footprint Group has been working on developing this antibiotic footprint tool and to improve an understanding of environmental considerations. And this is our most theoretical work group, but they actually have applied for funding to be able to measure antibiotics and resistance genes in various environmental specimens in water, groundwater, soil. They are also working on understanding the breakdown of antibiotics and understanding how things like wastewater treatment plants impact what antibiotics can end up in water. They also have been working actually on a very practical thing, which is friendly antibiotic disposal, so that people don't flush the leftover antibiotics down the toilet, but that they can bring them back to pharmacies or other sites for safe and effective disposal. So how do we talk about stewardship? This is extremely important. A major thing when we started the conversation was not to point fingers. And so we're very careful about the language that we use. Stewardship is the process of improving antibiotic use. It recognizes the importance of antibiotics, which are essential to human health care, veterinary medicine. It's a shared resource. Optimizing use benefits everyone. And any kind of antibiotic use leads to resistance. And there is some contribution from every sector using antibiotics. And we focus on optimizing the use, not eliminating the use. We recognize that human, animal, and environmental health are inseparable. A lack of proof of harm is not an argument for irresponsible use. And greater abuse in other disciplines is not an argument for injudicious use in yours. The acknowledgement that there are unreasonable critics who exaggerate the harms and fail to acknowledge real benefits, and that behavior change amongst everyone is key. We talked a little bit earlier about some of the Ds. We've added a few. Diagnosis, using an antibiotic only when clinically indicated, choosing the right drug, the right antibiotic for the infection and the patient, giving the right amount, the dose, the duration for the right amount of time, and de-escalation, switching the drug or route to better target the treatment. We recognize that there are competing priorities. That's always a tension between public health and individual clinicians, the good of the whole versus individual patients and individual animals. The definition of optimal, judicious, or appropriate are challenges. What are the low-hanging fruit for stewardship in each field? How can we set goals and identify progress without the data that we want? How can we get data on antibiotic use? And how can we design meaningful research? Also, how can we communicate effectively across fields and with the public? Well, in Minnesota, we've been very lucky because we've had a long-standing, excellent working relationship amongst state agencies, and this has really enabled us to move forward. The Department of Health has worked with the Department of Ag and Board of Animal Health and Pollution Control Agency in the past on things like variant influenza, on avian influenza, on various other issues. Academic excellence at the University of Minnesota, as well as the Minnesota Department of Health on antibiotic resistance research, large and progressive livestock industries, advance and engage healthcare industry and quality organizations, an academic health center that has medicine, veterinary medicine, dentistry, pharmacy, and public health, all under an academic health center at the U. And we've also been really fortunate in that we have had a number of our folks, Randy Singer and Peter Davies, who have been active participants in our One Health collaborative, also working on the President's Advisory Council on combating antibiotic-resistant bacteria. And so this has really enabled the success of our One Health collaborative approach. Here are some of the things that we have been working on over the past year. This includes information on milk and antibiotics, and explaining that there are not antibiotic residues in milk, and the sorts of things that the Department of Agriculture does to ensure this. We also have put out on dentists. There's a lot of overuse of antibiotics because of misunderstandings around when it's appropriate to use antibiotics for prophylaxis for dental procedures. Here we had folks from our collaborative at the Minnesota State Fair, and we tried to partner an animal person with a human health person or with an environmental health person, so we'd have some diversity in answering questions. We have had some exchanges where we've had our veterinary colleagues come to the University of Minnesota infectious disease pharmacy to learn how human stewardship is done. We've had exchanges at a dairy farm to learn how antibiotic stewardship is done at a dairy farm, and we are planning a trip in December to go to a wastewater treatment plant. Finally, I want to end with a screenshot and the URL for our website. We have a lot of information on there. We have our strategic plan on there. And if you're interested, you can sign up, and Dr. Bedoin sends out a monthly email on what's new in antibiotic stewardship, and we encourage anyone who's interested to join us. And you can see here we have quite a wide variety of One Health partners from across the various disciplines. With that, I would just like to end with a quote by William Shakespeare. "It is not in the stars to hold our destiny, but in ourselves."